I audible?
Yes, Pooja.
All right, ma'am. Shall we start?
Pooja, we have 4 minutes. We can start in 4 minutes.
All right, ma'am. Okay. Confirm if there's an echo to my voice. I could. I was able to hear an echo to my voice. Is it still the same, or is it clear now?
I can hear you. It's not clear to me. I'm not sure if my network is fine or not. Prasanna, can you confirm?
I'll just.
Pooja, your network is low. Pooja?
Yes, sir.
Your network is low. Preeti, we could hear properly. Your network was.
So it means, Pooja, your network is not good.
So is it better now? The voice is better
There's
now?
a lag. There is a lag.
We'll try changing the internet settings, ma'am.
Okay.
How about now, ma'am? Is it fine?
Yeah.
Better. Yeah, fine.
The audio is also clear now, ma'am?
Yes.
Pooja, have you started?
Not yet, sir. I thought I'll wait till 4 o'clock. If we can.
It's it's 4. If you can start, Pooja.
All right, ma'am. Okay. A very good afternoon to everyone present here virtually. I would like to cordially welcome all of you to today's webinar on dysphagia and stroke in account of the World Stroke Day 2021. I, Pooja Sriram, I'm going to be your host for the program. Before I invite the speakers to commence their talks, I would like to take an opportunity to very briefly tell you about the significance of today's of celebrating World Stroke Day. This was an initiative that was taken by the World Stroke Organization. It aims to spread awareness among the masses regarding its serious, debilitating nature and high rate of incidence. It seeks to educate people to notice early signs of stroke and to manage it as soon as they can to reduce damage caused by to an individual and to increase their chances of survival. It also provides a platform to urge decision makers to form and implement policies at local, national, and international levels that will improve stroke prevention, access to acute medical care, and timely support to survivors and caregivers. The 2021-22 campaign focuses on awareness of signs and symptoms of stroke and advocacy for on-time superior quality of stroke intervention. Taking these points into consideration, the organizers of SFSD India decided to call upon an excellent panel of speakers who will be talking to us today about dysphagia and stroke. A few housekeeping announcements before we begin. Participants are requested to keep their audio and video off for the entire duration of the program. If you wish to ask a question, kindly tap on the hands up emoji on Zoom to request for attention or type your question in the chat box. Please be respectful to the speakers while interacting. Only unmute yourself if you wish to interact with the speaker when given permission to do so. This event is being recorded and streamed live on SFSD India's Facebook page. It will also be available for later viewing on the same platform. Hence, kindly refrain from recording or clicking screenshots for personal use. No certificates will be provided after completion of this webinar. Our first esteemed guest speaker for today is Dr. S.P. Goswami. Allow me to introduce him to you. Sir's CV was so extensive, it took me a really long time to cut it short and present it before you. Dr. Goswami is going to be talking to us about epidemiology of dysphagia in stroke. Sir completed his BSc Speech and Hearing in 1995 from Aish Mysore, MSc Speech and Hearing in 1998, and PhD in Speech and Hearing from 2005. He did his postdoctoral studies from 2013 to 2014 in the University of Illinois. He has a vast experience of 23 years. His areas of interest include aphasia, aging and neurocognitive communication disorders in adults and elderly, organization and planning of telepractice and issues in disability. He's presently employed as a professor and head of Department of Speech Language Pathology at Aish Mysore. He has held many respectable administrative posts in institutional and national levels. His contributions to the field of speech and hearing include published papers in peer-reviewed in-house national and international journals. He has guided postgraduate and doctoral students for their dissertations and theses. He's presented lectures and talks as guest speaker in national level seminars, webinars, workshops, and conferences since 1999. He is responsible for having written chapters in books, monographs, and for having created test materials for neurodeviant population. Most recently, he was conferred on the Dr. N. Ratna Oration Award at the 52nd ISHACon held at PGI MER Chandigarh. He also received the Dr. B. Raghunathan Award for Best Paper in Language titled Effectiveness of Semantic-Based Treatment in Persons with Aphasia in the 52nd ISHACon. Sir, I welcome you to share your screen and present your talk to the audience. Thank you.
Thank you very much, Pooja, for that nice introduction, and hope I'll try to do some justice to the topic what you have given. Let me be very honest in this area that yes, I work in the area of aphasia, but my area is more towards in terms of language interventions and in looking for their quality of life. And I do understand that the dysphagia is one of the important components when it comes to quality of life. Though I have not worked directly, but I have been indirectly working or involved in some of the collaborative research works, either at a doctoral level or at a project levels in the area of dysphagia also. And thanks to Gayatri Krishnan, who pulled me into this area. Usually I'm a very self-centered approach I follow in terms of aphasia and all, but I have a very little knowledge. I'll try to do justice for that. So if you have any queries, I'll try to answer for that. Before I go to the presentation, one need to understand that when you look into a stroke can occur in any part of the brain. And when any part of the brain is involved, definitely we all understand that brain works as a system, as a whole, rather than bits and pieces. So anywhere, whether it is at the cortical level or whether it is a subcortical level, or whether it is in one area or it is in X area or Y area, it will have an impact on swallowing. It will have an impact on communication. It will have an impact on motor. It will have an impact on cognition. But what becomes more obvious, which recovers, which does not recover, I think still the researchers are finding out. Then again, it also depends upon the extent, the timing with which a person has availed these services also. So if you look into, like we all would have studied, that whenever a person is having a stroke, the primary areas, okay, or the primary somatosensory areas, especially the motor supplementary areas like your area number 1, 2, 3, 4, and 6, which we also look into that, okay, these are the areas which do play an important role in communication or in terms of language, but they do also have an impact on swallowing, the cortical processing of swallowing, including your motor regulation and execution. So when we have been talking about the execution of the motoric movement, swallowing is also a motor movement. Though it may not have a major impact, but it can have an impact. Why I'm trying to say again and again is that we need to understand that any repercussions, any subtle change in the brain, it's one of the finest thing which God has given it to us, that the fine tuning of each area is so well integrated that if there is a minor change also, either the neurons or the different areas will take over. If they don't, definitely there will be some sort of deficit can be there, and which can also be seen in the form of swallowing, which several researchers are trying that, okay, look, these are the areas. Similarly, when you look into the anterior cingulate areas also, they do have area number 24 and 32. They do have certain high order processing, high order motor processing. And when you, wherever the word motor is involved, definitely it also involved in terms of swallowing. And I think all of you will appreciate that swallowing cannot be viewed as an isolation, because swallowing also involves your motoric, your executive, your comparison. So basically the brain does the three important things. What it does is store, retrieve, and compare. All these three phenomena will also takes place whenever any swallowing issue also takes place, because the person has to carry out a fine motor coordination, and any variations, especially when you have area number 24 and 32, do a certain or can influence. Similarly, especially into your orbitofrontal cortex, especially your area number 10, 11, 12, 44, 45, and 47, they are saying these are unclear. Okay, but area number 10, 11, and 12, they talk about into prefrontal cortex, that these are involved into cognition. And when we have a cognitive issues, especially when you talk about certain degenerative individuals, the individual forget to swallow also. So there are issues with that. So in the initial stages of persons with stroke can have or may have certain issues, but the areas are not very clear. That's what the researchers have said. And especially into parieto-occipital areas, also the area number 7, 17, 18, or 40, they also are involved in sensory processing of swallowing. That means there is some component to different areas. So you can just look into that the number of areas which I am talking are increasing. It is not a static instance. Similarly, when you look into a temporopolar cortex like area number 22 and 28, though it is unclear, but insular cortex does have an important role in terms of gustatory input. Internal capsule in terms of functional connection, what we talk about the cortical and the brainstem, that is also an important function in terms of swallowing. It does place thalamus, your sensory and motor input processing via thalamocortical and thalamostriatal pathways does have an important. Basal ganglios, we can always look in terms of gating of sensory output, and cerebral peduncles. Descending pathways from the cortex does have one or the other areas which are involved. Similarly, your brainstem, your cerebellum. So what I'm trying to say is, you name any part of the brain, it has a role in terms of swallowing. So when a person is having a stroke, the lesion can be anywhere, starting from the cortical to the subcortical, from frontal to the temporal, from occipital to the parietal lobe, you name it, any of the lobes or any of the areas or any of the hemispheres. If you look into even a subtle change, it can bring. The impact can vary. That can be a difference. So you can look into the number of areas which are involved. If you look into the good number of areas in the brain, does have a direct impact, but other areas have an indirect impact. All of us will appreciate that these are interconnected to each other. So any impact or any of the fibers, even if they get affected, they will have a issues, especially when it comes to the cortical, midbrain, brainstem, or in the cerebellum issues. So you look into the number of areas, though that's we can always say that we have been talking about the speech is an overlaid function. So we can always say that all the areas, I will not even say the overlaid, but I will say multiple laid functions. Okay, so these are integrated to each other. It is not only in terms of language or in terms of cognition, but they do have a role in terms of swallowing, because swallowing does involve your cognitive skills, does involve your executive skills, does involve your motoric skills, does require your processing skills. So you name it, you have it. So if any of these issues or any of the components or any of the brain part, when it gets affected and has got an impact on any language or cognition or a motoric, definitely the person will also have certain issues in swallowing also. That's what I understand, and that's what I believe, that you cannot isolate it, but you have to look the condition in a holistic manner. So this is what I have been talking about. You name it. So majority of the brain areas contribute to your eating, swallowing, and full process. So that means these are integrated to each other. These have a role. The role may be subtle or the role may be major. Therefore, any kind of stroke can interfere with the normal process of eating, drinking, and swallowing. That's what we look into the dysphasia component. So depending upon whether he has got issues in eating, he has got issues in drinking, or he has got issues in swallowing, whether that can lead to dysphasia, or it can lead to isolation, or it can be more than one per se can also get effective. So what our data says, to be honest, if you look into the published data which is available in India, which I always say that the data what is presented in India, or the research which is present in India, is, I will just say, at a very low level. So the number what we are presenting is not even 1/10. Forget about 80%, 90%. I'll say it is just very, very low rated numbers. So they have been talking about that stroke is the 4th leading cause of death. But this is as per the ICMR data. But if you look into the number of people who have death due to stroke is much more. Yes, the person who is having cancer, diabetes, cardiovascular disease are supposed to be the first. But one need to understand that stroke is more fatal. When I say stroke is more fatal, it is more fatal in terms of the survival rate. It is more fatal in terms of the comorbidities. It is more fatal in terms of the economic impact. It is more fatal in terms of the losing the various activity and participation, including your vocations. So I would always say, when you look into the fatality and when you look into the impact of stroke is much more than your cancer, diabetes, or cardiovascular diseases also. And it is supposed to be 4th leading cause of disability adjusted life years. I would always go step 1, and that it is not the 5th. It can be the 1st leading, because all other conditions, when you look into, have some sort of medical treatment which a person can speak out, a person can eat, drink, but a person with stroke will have major issues, because you all will appreciate that communication is one if domain, if it gets affected, the impact of that communication is much more than when you look into a motoric or when you look into visual or any other disability. Because if you can communicate, you are able to integrate in the society. You are acceptable in the society, but if you are not able to communicate, your acceptance rate is low. And when you are able to communicate, then you can always say, I am able to eat this, I am not able to eat this, I am able to swallow this, I am able to drink this. But when you are not able to communicate following a stroke, you are not able to say. So the role of the clinician is very important, or the role of the speech language pathologist and a swallowing specialist is very important, that we understand those subtle changes when we assess him in terms of swallowing. So ladies and gentlemen, please note the number is much more. Okay, please understand the number is increasing and it will increase, and the number will increase further because the survival rate has improved, the medical facilities have improved, the affordability of the people have improved, the awareness has increased. So hence the survival rate has increased, but the comorbidities, the associated deficits of these conditions in terms of swallowing, cognition, communication, motoric, vocation, you name it, these will get affected, and that is what the quality of life is coming down. Hence, as a speech language pathologist, it is our primary role that we look into. So though technically it is the fourth leading cause. So when you look into dysphasias, we always look into the epidemiological data which we have, and if unidentified, aspiration and pneumonia is, I think all of you, when you work in hospital setup, you can always say that there are aspiration pneumonia which are unidentified and they can be certain times fatal. And the duration of the hospital stay, the more the hospital stay, there are more chances of having swallowing issues, and the healthcare cost which is evolved or involved both in terms of stroke, in terms of swallowing, in terms of evaluation, treatment and assistance, it adds to an economic burden to the family, to the persons with stroke. So most of the time when you look into, we have been following this medical model, and in the medical model, they are emphasizing on the survival. But after the survival, what happens? Most of these persons will have issues, and several times because of these swallowing issues, which would have been underdiagnosed or not noticed, these persons might choke up and might have issues with reference to what we call it as some or the other issues can have in terms of swallowing, and they might have aspirations also which can be fatal also. So when you look into the epidemiological data, what has been reported is that the prevalence of dysphagia varies between 8 to 80% following stroke. That means the number is high, and these are the reports which have come from the different screening tool what have been said. When they are used water swallowing test, the range is between 29 to 57. When they had used VFSS, the range is between 35 to 80. And when they had used bedside assessment, it ranges from 8 to 55. Others, it ranges from 27 to 64. So what I'm trying to say is that if you look into, the number is quite high. That means almost every, you can always look into that every person with a stroke will have swallowing, but the duration might be. So we need to understand that as a speech language pathologist, we need to look for the advocacy that SLPs are required to assess the swallowing in the initial stages, so that we can improve their overall quality of life, so that we can improve their productivity and can look for their independency and independent members of the society. Depending on the site of lesion, when you look into the cortical, okay, almost whenever there is a lesion at the level of cortical, we all understand that the voluntary control of mastication and bolus transport is also being monitored by your cortical structures. Your precentral gyrus is an important, and especially when person is having a paralysis in the right side. So usually your tongue, your lips, your pharyngeal will also have paralysis, will also have issues. And in case if prefrontal cortex or frontal is involved, there will also be having a cognitive issues also. So in a person, whenever there is a cortical structures are damaged, we will find that there are issues with, like in the previous slides also I've said it, that these individuals can have issues with swallowing. Brainstem, though we say brainstem is rare, but please understand it is severe and more fatal. All of understand that if the stroke is at the brainstem level, survival rate is low, but if the individual survives, the prognosis will be good. Same thing holds good with individuals. These brainstem lesions will have issues with the swallowing, but they will be able to improve. And especially when you look into the lesions like prevalence in terms of Wallenberg syndromes, sensations of mouth, tongue, cheek, timing, these all you can look into your motoric movements, okay, does have a play in this role. So definitely they will have, so even when we have the subcortical aphasias or the subcortical level, there can be issues. And when you look into your Brunstrom's grading, they also have said it, that significant association lies between grades and severity of dysphasias. And they say the grade 1 to 3 has got a significant dysphasias index. So what they are trying to say is, whenever any motoric movement gets affected, either due to a lesion at the cortical or the subcortical, it will have an effect on swallowing. When you look into the age, the younger individuals, it is reported that it is better. And in older individuals, the age-related changes, because of the age-related changes, the strength and in terms of control, there might have poor compensations. But one thing we need to understand, this age, what these people have been talking is only in terms of adults and elderly individuals. But there have been no reports which are for the children, because stroke is not age specific. Children are also vulnerable nowadays. Even young kids, as the age as young as 1 year, 6 months, do get stroke. So there are possibilities which this number or these data, whether it is ICMR or Indian population, have not talked about this. So depending on type and number of the CVAs, hemorrhagics, they have more impact than the ischemic type of strokes, and that holds good for other deficits also. Marginal significant association between type of stroke and severity of dysphagia has been also reported. There have been another one study in India by Krishnamurthy et al. They have said there have been no enough evidence to confirm the effect of in terms of type and severity of stroke. But they have said that if the number of strokes are more, multiple strokes, the lesion will be more, and as a result, the probability of having stroke is quite high. As a result, probability of having swallowing is quite high. Depending on time of evaluation, immediately after stroke, okay, that is what so they say, less than 1 to 3 months post stroke, they say spontaneous recovery for a few weeks, and then there is a possibility that they may or may not have. But usually between soon after the stroke, or even when you look into the first few weeks, they will have certain issues with swallowings. Okay, they might say, okay, that he's not taking anything oral, but over a period of time you look into. Severity, when you look into more severe stroke, there are chances of having more probability that the individual is having a dysphagia. But again, the dysphagia, when you are talking about, some individual look into from a symptom, some look into from ICD classification, some talks about instrument. Though there are variations, like how we have variations in terms of our professional approach when we assess it. There are also variations when it looks into the definition of the dysphagia. But we need to understand that if the individual is not able to drink, swallow, and eat, you call them dysphagia, you call them swallowing, whatever you call it, they are not able to intake. Their intake abilities in terms of liquids, semi-solids, or solids is getting hampered, and as a result, their overall quality of life of their as well as the caregivers is getting affected. Complications. Basically, the complications look into the poor. Complications are less when you look into the individuals which have early, but if the complications are long, complications are more, and which has got a long-term effect, the prognosis can also get affected. Increased hospital stay leads to some sort of swallowing issues. Poor functional outcome can also be, especially due to aspirations or the pneumonias. And individuals have reported that around 10 to 40% of hospitalized individuals does have a high risk of having stroke, having swallowings. So most common in acute phase is combined effect of your immune suppression, poor oral health, and high prevalence. So especially when these individuals are during acute phase, these are very, very common. When you look into the oral health will be very low, high prevalence of dysphasias, and immune suppression can also be low. So as a result, these individuals have high probability of having strokes. So in Indian scenario, when you look into, as these are the most of the reports which are there in the Western, but Indian scenario, when you look into, there have been one study which is done on dysphagia and associated pneumonia in stroke patients from India, that is by Krishnamurthy, Radish and et al. And this study, which was done in 2020, what they have reported is significant observations of their study. They have reported that no enough evidence to confirm effect of age, type of stroke, gender on prevalence of dysphagia in CVS. So this is one perspective we need to understand, that in India till 2020 we are not very clear, or the researchers have reported that age, type of stroke, gender prevalence, gender do not have any role in terms of prevalence. What does it mean? That stroke sees everyone equal. Okay, like when we talk about it does not discriminate on age, type, and gender. That means all of us are vulnerable. Most studies use only clinical bedside assessments. So when they look into bedside assessment, there is a possibility, because initially the more emphasis would have been done on the life than the basic things. And most of the time there is this research have read that it is the physician which has conducted the evaluation and not the SLPs. So when the physician does, he looks into more of survival point of view. But when you look in from a swallowing point of view. So once the person survives, then swallowing becomes an issue. So who does, in what stage they does, that is more important. And that's why the numbers are getting suppressed. No uniformity in bolus characteristics, like even the bolus characteristics, what they have used is not clear. There have been no clarity in terms of definition of pneumonia. Almost all of us have seen, learned, studied that any patient who is hospitalized for 10 to 15 days, several times you would have heard it, that he has developed pneumonia, he has developed infections. But no one says that when pneumonia infection is there, what happens to his swallowings? So the dysphagia has ranged between 11 to 87. So that means the report, what has been 80 to 80%, it is matching. That means we need to understand the variability of dysphagia is present, will be present, and it is going to increase. Relative risk of developing pneumonia is around 5.82, which again reflects that when you have a pneumonia, definitely there can be issues. Hospital stay 10.8 days versus 6.5 days. That means if the number of days increases, the probability of having swallowing will also increase. So chances of anomia versus odds ratio is in terms of around 10.99. So what do we learn? So what is our understanding about this condition? So we look into that stroke is increasing, and so is dysphagia, so is our group. We need to understand, ladies and gentlemen, that the number of stroke patients are going to increase thanks to better medical facilities, thanks to longevity, it is going to increase. And when it increases, the dysphagia component is also going to increase. And when it increases, it is also directly proportional to our group. So people like all of you who are working in the dysphagia and all, that we need to have our assessment tools, our attitudes, and our approach, which are more patient oriented, which are more caregivers oriented, so that we can do justice to them and we can prove that as an SLP, we have a major role in improving not the life, but overall quality of life. And if the person cannot intake, the intake gets affected, the swallowing gets affected, everything is, then you will look into poor prognosis in every case. So there are no enough specific data which is related in dysphagia. So people who are at a UG level, PG level, or whenever they write a project, we need some sort of data management. So we need a data if you want to influence our policy decision makers. Available data suggests high prevalence than Western countries. Yes, there are two reasons now we are talking about high prevalence than the Western countries. One, the generation what you have been looking into now is the generation who was born in 1960s or 70s, right? So when these individuals have been born, okay, or who have been born on 70s, now these are the individuals who are moving towards the elderly group. So these individuals, even the lifestyle, the adaptation, the accommodation, and the services what they have availed might get different. And that there is a change in the technology, because when you have got a refrigerators have come, definitely we have stopped eating the food what we used to eat. Like when the refrigerator was not there, people used to cook 3 times and eat. But now we cook one day and we eat 4 days, right? So definitely the consistency of food is changing, and even the adaptability is also changing. The oral health now, definitely people who are there, rural, semi-rural, even they have started taking care of themselves. But then thanks to other issues also, there is increase. So that number is going to increase. And not only with the stroke, but other conditions also. Higher chances of pneumonia is quite possible. And the financial stages. The financial and family and social burden is going to take a big number. And when we look into that, means the condition of the stroke, one time his life is, if he survives, the economical burden on rehabilitation is much more, which we have not calculated and which we do not know also, we need to understand. No professional guidelines for evaluating diagnosis. That means we do not have a standard operating procedures, okay, in the healthcare system. So when a physician sees, when a nurse says, no, he's able to do it. Yes, he's able to do it. But sometimes you'll say that after a few days he chokes, he develops pneumonia, and then there are chances that the person may or may not survive. If he survives, there will be several complications. So what can be done? So what we need to do is, all of us, we need to build a good registry, which can be at a national level. Now, like Government of India is talking about death as well as birth rate. If you read today's newspaper also. So similarly, we need to have, when we make these registries, they should include a holistic picture. Now, Government of India is also talking about a universal card where your whole health registry will be available, but there we need to, health details will be available. So we also need to understand that we add dysphagia also. The perspective, the survival to life. We need to look from the survival rate, the increasing. So when the survival rate is increasing, the incidence also increase, and our responsibilities are also going to. We do not have any healthcare policy. And when you look into healthcare policies, though it is there, but these are selective in nature. I always say these are selective in nature when I say it is mainly towards the life, but not survival. So food, that's what they are talking. A lot of emphasis is being done. Government of India is taking measures in terms of midday meal. And the state of Kerala also introduced a midday meal for elderly individuals also. So that means healthcare policy, what happens to a stroke patient when they do not have a family support systems. Like now, a lot of people don't want to have their family and all, they wanted to live single and all those things. What happened to that? So we do not have a policy system. That is one part. So under policy system, we also need to look into the assessment and what protocol we need to look into. And we also need to have good trained manpowers. So when we look into the registry should be at a national level, which should include at a multi-centric approach. When you look into the perspectives, the survival to life is from living to the quality of life. That means our perspective need to change from life to quality of life. Policies, we need to have policies for both assessment, guidelines, and SLP as a team member. So somewhere we have to talk, other your manpower, we need to look for your indigenous resources, adequate infrastructures. When I talk about adequate infrastructure, I mean that we need to have good clinical setup, where good clinical tools are available, where good clinical SOP procedures are available, and professionals are available to guide them, to support them, and to provide services so that they are independent members, they are productive members, they can eat well, they can drink well, they can swallow well, And when they eat, drink well, I think their overall quality of life improves, their productivity improves, their identity improves, and they will be a less burden to the nation. Otherwise, if these issues are not solved or resolved at this level, the incidence is going to increase. And we have been talking about, if you would have looked into this hungry index and all, it might increase also, because these people are not able to eat. Though they wanted to eat, they can afford it, but they are not. So there can be issues with this. So with this, I close this presentation, which was half an hour, but I wanted to dedicate this presentation to two of these people. There have been a bad day today. I lost one of my classmates yesterday, and today I think whole of Karnataka is in a sad state. They have lost another one icon. So this presentation is dedicated to both of them, and I pray to the Almighty that their soul rest in peace. Thank you very much. If you have any clarifications, you can please ask. Hope I have not overshooted the time. I could not hear you, please. I think there is something wrong.
Am I audible now, sir?
Yeah, now you are audible.
Yes, sir. So you may respond to questions that will come in the chat box, sir, because of time restraint. So if participants have anything to ask Dr. Goswami, they can please put it up in the chat box, and sir will reply to you there. Sir, I thank you very much for this comprehensive explanation on the topic. I'm sure that it acted as a refresher course for most of our participants here. We'll move on to the next speaker for today, a very eminent personality, Dr. Jayashree S. Bhatt, and her topic for presentation is Burden of Dysphagia on Stroke Survivors. Allow me to introduce her to you. Dr. Jayashree has completed her MSc and BSc in Speech and Hearing. She also holds a master's degree in psychology. She's completed her her doctoral studies in Speech and Hearing. At present, she is appointed as a professor at the Department of Speech and Hearing, Kasturba Medical College, unit of Manipal Academy of Higher Education, Mangalore. She has an astounding work experience of 35 years. She is the founder head of Department of Speech Pathology and Audiology at KMC, Mangalore. She is the founder principal of Taranga School for the Hearing Impaired. She has also provided clinical services at Father Muller's charitable institutions and Sayadri hospitals. Her areas of interest include dysphagia, language disorders, and voice pathologies. Her contributions to the field of speech and hearing include more than 100 national and international paper publications. She is an active member of professional bodies created for the cause of disability and rehabilitation. She has authored 5 books in the field of speech and hearing, and she has been invited as a panelist, guest speaker, and chairperson in national, international seminars, conferences, and webinars. She has several national and international funded projects to her credit. She's received a Lifetime Achievement Award in the field of speech and hearing. She also acts as an expert consultant for organizations for the differently abled and is actively involved in social causes. I warmly welcome you, ma'am. I request you to share your screen and start your presentation.
Thank you. Am I audible?
Yes, ma'am.
Okay. Just this morning, when we were taking rounds, there's a patient who has come back. This is the 4th time that he's back. Every time he gets all right, he goes back home. And now he has come back again with dysphagia, a stroke survivor. And this has been the ongoing scenario. We keep seeing so many such patients often. And this is the time, I'm glad that in the current scenario, there are so many people, so many professionals, especially speech and hearing professionals, who have focused on dysphagia. And it's my pleasure to share whatever little experience that I have regarding dysphagia and stroke survivors and the burden of it. I thank the organizers for giving me this opportunity. Stroke is, I think Dr. Goswami has already said that it's the second leading cause of mortality worldwide, is the main reason for long-term disability. Often we see a lot of these patients, when they have stroke, they go back home and, they ask for physiotherapy so that the motor movements are all right. Often they overlook dysphagia and they come back with repeated attacks of pneumonia. So this long-term disability disables not only the person, but the whole family. And it is often associated with multiple medical complications and loss of healthy lived years. Again, it's very important to know that often there are many people who are born with disability. There's a lot of difference between them and those who have lived normally and suddenly lost their, life. And losing the communication efficiency or the, chance of communication can be the greatest loss for a human. If I have to quote the earlier times, as you get older, the moment the person stops talking, then, they would invite all the family members, please come over. Yes, stop talking. I don't think he's going to make it anymore. I'm talking about the era wherein the stroke survival was not so great. Next, when the person stops eating, it is confirmed that he's just not going to make it. That was the, earlier understanding. But even now, whenever a person doesn't eat well, whether it's a child or an adult, it's always viewed with a lot of concern, because eating is considered as a life survivor skill, and it is very much required for a person to live. And stroke can affect all these things. And post-stroke dysphagia, working in a hospital setup, we see in and out so many people with dysphagia. It can occur within a few hours or last for days or months, or many times, they do well and they come back. We'll go into those details a little later. And this post-stroke dysphagia is associated with increased mortality and morbidity due to aspiration pneumonia, malnutrition, and many of them, though they recover almost 11 to 50%, they have dysphagia even at 6 months. These days, we see a lot of these adults or geriatric population who have a problem of swallowing. Microaspiration is very common. And many of these elderly people, they just come to the OPD or they just come to the casualty on an emergency basis when things have gone beyond their limits. And many of these elderly people do have stroke. So there is a lot of, interaction that is going on between the two. Dysphagia is recognized by WHO as a medical disability, having profound psychological and social consequences. As I said, it's not only that the bystanders think, okay, he's not eating, he's not going to make well, but if the person cannot eat on his own, and it will affect him psychologically, and socially the person will be, trying to stay away from society. So patients with dysphagia are 3 times, and those with confirmed aspiration are 11 times likely to develop pneumonia. But what is interesting is consequences associated with post-stroke dysphagia mirror other dysphagia etiologies. A person can have dysphagia for many reasons, and this stroke only magnifies it or adds on to it. That's what I meant by microaspiration in geriatric population. So these people can have malnutrition, dehydration. This is something which is very sad. When we go to the patient, we see that they have a lot of fissures on the lips or on the tongue because of dehydration. and recurrent cough. Cough can be very disturbing or distressing to a person at any age, and more so for a stroke person, especially in the elderly population. And their compromised nutrition hydration can be a little burdensome for the family, because they do have to really plan for a different food, appropriate food, and safe food for people with stroke. Often they have social isolation. Social isolation can be even things like the meal time is no more a family time. It's the meal time for that particular individual. So he's isolated even from the family gatherings. And thus the quality of life gets reduced. That's why some of these authors, they say that post-stroke pneumonia is multifactorial and dysphagia should be considered as just one of the risk factors. So there are different schools of thought, because right now we do not have substantial research on dysphagia, especially in India. This Dr. Goswami has explained in depth about neural circuitry, but what's important is that stroke-related lesions anywhere in the cortical or subcortical or in the brainstem, anywhere can result in dysphagia. And this dysphagia often is not clinically significant. That means it is not easily observable or easily evident. So dysphagia, why we are all here? We want to prove, or we want to show to everyone that if dysphagia is recognized early and managed appropriately, the person's quality of life or eating, swallowing, everything improves very well. As I said, post-stroke motor recovery has received close attention, but there is very little information on dysphagia recovery. And the recovery patterns of motor movements are so different from recovery patterns of dysphagia or swallowing. And even the compensative mechanisms are so different. We all know that the area which is used for swallowing has so many muscles and really challenging for us to understand. There are many factors that it can be the cognition. One of the major factors that I find very, challenging. Often you go to the person because of the or because of the aging, because of several other factors, is not able to be with us, is not aware, is not able to focus, is not able to do things. So the cognition can be a major issue. And whenever the person is cognitively disturbed, it becomes a Herculean task for us to really pinpoint where exactly is the problem or how to overcome the problem. So cognition can be very challenging. And particularly in stroke, the head and neck postures, often, the person with a stroke has deviations, and because of that, the whole body posture, it changes, particularly the neck posture. And the moment their mobility is reduced, we all know that for any person to swallow, it's very important to be stable. That means especially they should be sitting without any instability. The leg should not be hanging. It should be firm. So these things can be challenging. And many of them, they end up having a lot of mobility problems. They end up being on the bed. And often when they're on the bed, their neck is nicely elongated, stretched, which works against swallowing. There can be a lot of oropharyngeal or laryngeal factors, like dysphonia is one of the things, or unilateral palsy, So these things also can add on, because often if the person has, if it is just a dysphagia, a dysphonia, it doesn't matter much. But if the person has communication errors, then he's not able to say what exactly is happening. And this becomes the guesswork for most of the clinicians. One more challenge is their taste and smell. A lot of these who have altered taste as well as smell, particularly when they're on medication, they have a metallic taste. Sometimes the smell gets affected. And these smell and taste are very important for eating. And the moment the person has smell and taste deviations, the swallowing becomes a challenge. We see it a lot on the bedside because eating in the hospital is a big challenge for a normally functioning person too. And it can be even more devastating for a person with stroke. We have seen a lot of these patients with vision and hearing problems, which can be very challenging for a clinician to decide. Gastroesophageal functions. These days, GERD is the, what would say, common terminology, which is used across the age in every homes. And GERD is very common whenever the person is on any medication or is having any health issues. So this can also add on to the swallowing. The breathing, oxygen saturation. COVID has given us a lot of challenges with breathing and cough. And COVID has given us a lot of challenges with stroke. That means post-COVID, there are many people who end up having stroke. Along with that, they have breathing and cough challenges also. So this can also influence. Then the basic appetite. There are many people who just cannot eat. If I always ask my colleagues, there are some people who can never eat from a tiffin box. There are some people who can eat everywhere. So there are a lot of difference, because if it is given in the tiffin box, my hunger is less. So in a stroke patient, there are so many factors, not just the ambience and all. It is even the mobility which is restricted, which can indirectly influence the appetite and which can indirectly influence the cooperation for swallowing assessment or intervention. There are many who do not like to be dependent on others, and stroke actually affects their self-feeding abilities, have a major impact because every person's eating pattern is different, and whoever is fed with someone else. I was giving you the example of the patient that I saw in this morning. So here is the wife who gives food to the husband, and she's fed up because this has been happening often. And in spite of repeated requests, she just doesn't understand that she has to give small quantity. She just goes on pouring into his mouth. And even if he coughs, she just doesn't bother. And this person ends up in casualty every now and then. So this is what happens whenever the self-feeding capacity is reduced. The psychological and social factors are related to the same thing again. One of the factors which affects swallowing is oral care. And this oral care is really challenging in this pandemic era because of, the mask and all that. Because the floor of the oral cavity is altered by the stroke itself. We know that there can be different sensation in different parts of the mouth, or by concurrent use of the antibiotics also the oral cavity gets disturbed. And candida infections are very high. Over and above that, the oropharyngeal residues and dental plaques are also very common. And believe me, this oral care or dental hygiene increase the risk of pneumonia, and we often forget it. Unless and until the team works together, the family, the nursing care, and SLPs, this is something which we often overlook. That is the reason I particularly inserted this information here, because this can be a simple thing. See, when a person has many things which are all right, everything will be fine. But if a person has one small thing, every small things can go on adding up and the person can have a trouble. Again, patients will have difficulty in self-care and have to depend on someone else. And that can be pretty challenging because they are, unable to say often many things because of cognitive factors or communicative factors. And the person next door has to understand. That becomes a challenge. So swallowing can be subconscious. That means this is something that we observe in most of the stroke patients. We go on swallowing our saliva knowingly or unknowingly constantly. And whenever this is disrupted, we see a lot of drooling that's happening. Sometimes the swallowing can be reflexive as a protective mechanism. We try to swallow, and if there is something which is trying to enter into the windpipe, immediately there is a cough reflex, and this can be absent in stroke. When these two are absent naturally, the nutritional swallow itself can be a challenging thing. Why I have put this up is that often we look into only the nutritional swallowing by overlooking the first two aspects. It's very important because it is realized that the aspiration pneumonia occurs not because of only the external food. It also can be because of the saliva aspiration. So we need to look for impairments in body structure and function, and whatever the compounding factors, that is comorbid deficits and how they're impacting this person. And whenever there is dysphagia in a stroke patients, how is it, limiting his activity? How is it limiting his participation in society? All these things are to be taken care of. More importantly, dysphagia as it is affects the person's quality of life and significant others. Just like what I said, this morning's case, the wife is so tired of doing everything. So it's very important to address both the issues so that both the needs are being met. Often, I've seen a lot of us going for a swallowing assessment on therapy and restricting only to mouth, tongue, lips, or whatever it is. That just doesn't help because swallowing is person specific. And I will swallow if only I want to swallow. Or I will swallow if only you give me the food that I like. So there are so many factors. So unless and until we try to understand the person who is eating, the person who it becomes difficult. Is it just the impaired swallowing efficiency, or is this efficiency affecting the swallowing safety? This is very important because our priority is safety first, and then only comes the efficiency. When it comes to swallowing, we have to be very cautious about pre-deglutitive. That means when a person is eating, even as he's chewing, is he aspirating? After everything is over, you just stand there and talk for some time, and after 5 minutes, he comes out with swallowing errors or with cough. So these are some of the things that I'm cautious about. And again, we all know everything about how to do all the therapies. I don't think the time will permit me to go ahead with this, but I would really request everyone who is going to help a person with stroke to prioritize pre-oral stage swallowing stage, and post-swallow stage. So unless and until these three are being, taken up, it becomes a little harder. So, by common, this is not to assess in or at bedside. The compensation or willingness to participate. There are so many factors. So it's very difficult to assess whether we assess it or intervene it. It's challenging. Whatever is said and done, whether it is clinical observation or instrumental assessment, this can be pretty challenging because disorder can be subtle, and especially in stroke patients, it is subclinical. That means clinical symptoms are not very evident, but the effect of that on the person's life, it can involve one or multiple levels, and based on the person's cognitive factors and psychosocial aspects, there can be a varied presentation. So dysphagia can be pretty burdening, and what is very important in post-stroke dysphagia is the multivariate nature as well as heterogeneity. This is the hallmark of post-stroke dysphagia. Presentation as well as in recovery, this is the hallmark. That means whenever a person has any dysphagia post-stroke, many of them do have, many of them continue to have. It's very important to remember this at every stage and understand the person and understand or plan person-specific, requirements. Unless and until we do that, we'll not meet the ends and will not have a successful or better quality of life for a person with dysphagia. I think I've just reached my time, 5 o'clock. Thank you so much. If there are any questions, let me ask. Thank you so much. Especially to team doing successful work and who are, we have a lot of hopes and lot of, things to look forward from this group. Thank you so much.
Thank you, Dr. Jayashree, for this very elaborate talk. Thank you for talking to us about the physical, social, and emotional issues faced by a stroke survivor. Our takeaway message from this is that we always need to keep in mind person-specific care and management strategies. Our next speaker for the day is Dr. Mansi Jagtap. And being the president of SFSD India, she would be talking to us about the role of the Society of Feeding and Swallowing Disorders. I shall introduce her to you. Dr. Mansi Jagtap's area of specialization is dysphagia across lifespan, neonatal, pediatric, oncogenic, and neurogenic dysphagia. She has 14 years of experience in the field. Her professional qualifications include BSc and MSc Speech Language Pathology and PhD in Speech Language Pathology. She was her merit holder for her master's examination at MUHS. She is a trained professional in FEES and VFSS procedures. She has served as a mentor for FEES training at Susan Langmore FEES workshop at Tata Memorial, Mumbai. She has presented numerous papers in national and international conferences, and she has 3 national and 4 international publications to her credit. She's been invited for talks at international and national forums. Ma'am, I request you to kindly share your screen and commence your talk.
Hello. A very good evening to everybody, and thank you so much for that kind introduction. As the president of the Society for Feeding and Swallowing Disorders, I welcome all of you to the World Stroke Awareness Day. And we've had some wonderful presentations by Goswami sir and Jayashree ma'am, who have given us very key important points to, as professionals, to keep in mind with respect to when we are dealing with stroke survivors and stroke patients. Society for Feeding and Swallowing Disorders is an initiative by diabetologists pan-India and abroad, with the common aim of serving people who have feeding and swallowing disorders. And we are a society for the people and by the people who are involved in the feeding and swallowing field. I now request the Secretary of SFSD, Mr. Prasanna Hegde, to proceed with the presentation. Thank you very much. And I wish all of you very fruitful and a very enlightening experience in the sessions to look forward to. Thank you very much.
Thank you, Dr. Mansi, for the introduction. So I would take it forward, and I will not take much time because there is a interesting panel discussion coming up. So, like Dr. Mansi said, it is Society for Feeding and Swallowing Disorders. It is registered under Karnataka Societies Registration Act 1960. And this society is registered in Karnataka, but it is pan-India registration with representation of 8+ states as of now. And we have 16 founding members from different states who have come together for a common cause. And there are the members' names are listed in the website, which I'll be showing in a meanwhile. And we have office bearers who are holding the executive council as of now. We have President Dr. Mansi Jagtap, myself, Prasanna Hegde, General Secretary, Preeti Shetty, Mr. Arun Balaji, who is the President-elect, and Bhushan, Fanidar, Dr. Gayatri, Bhaskar, Jignesh, Smita, and Sushmita, who are the EC members who are helping us. Our vision, per se, is the basic thing, which is government mandate that any non-governmental organization or non-profit organization, we would be going to the public with certain intentions to make them sensitize about, the burdens and epidemiology and, problems of individual disorders and how it should be seen. What is the importance of knowing about certain disorders, like how we heard from the experts in the previous talks. So awareness is the main thing for us, public awareness especially, and with the public awareness and public inclusive of other professionals as well as our professionals who are not really working in depth into swallowing and feeding disorders. And of course, welfare of people who are practicing in swallowing or feeding disorders, to help empower speech-language pathologists with skills and competence in swallowing by conducting different skill and competence training programs and bringing great content to them, with different intentions of or different levels of training, and also to have research and development programs to have evidence-based practice customized to Indian population. So this is the basis of our vision, and on which our mission also takes place and on a yearly basis, where we focus on certain priorities. So till date, we have been a part of some of the workshops and seminars, and we also ourselves conducted webinars to mark the celebration of Dysphagia Awareness Day. This is one of that which happened in January 2020, which was led by Mr. Fanidar. It was on workshop on feeding and swallowing disorders in neurological condition across the lifespan. And we observed Dysphagia Awareness Month, where we saw 2,000+ registration for the Dysphagia webinar series. And we had representation from 26 countries across the globe. There was active participation for 4 days long webinar. That is, every Sunday we had 2 hours on different topics in dysphagia. We also collaborated with different organizations on conducting a webinar on augmenting swallowing with Prasuram to mark the celebration of Dysphagia Awareness Month. We had great collaboration with us, and one of the key mission for us to take up is collaborating with associated professionals, medical professionals, as well as allied healthcare professionals, so that we deliver better service for dysphagia affected individuals. So this is our internet presence and social media presence. We have an official page for SFSD. You can visit this page, as well as right now this video is being streamed live on this page. And also we have a website, which is www.sfsdindia.com. All the updates about membership or the activities will be updated in that website. So with this, I conclude and would like to announce that membership to the society is open. You can visit the website and become a member and look at all kinds of membership and the benefits which are mentioned there. If you have any queries, you can always contact us or write to the contact details which is mentioned in the website. So thank you, Dr. Mansi, for calling me up for this, as well as the organizing team to have put up a great show to mark World Stroke Day. Thank you.
Thank you, sir. Let's proceed to the second part of today's webinar. We have an exciting panel discussion coming up in just a few moments. Ms. Preeti Shetty will be the moderator for this part of the program, but allow me to introduce her to you. Just give me a moment. I'll share my screen. Ms. Preeti Shetty, she has completed her BSLP from Mangalore University and Masters in Speech and Hearing from Bangalore University. She was university rank holder. She is doing her PhD at NIMHANS right now. Her areas of interest are speech production, speech perception, neurocognition, swallowing, neuroplasticity, AAC, machine learning and artificial intelligence, and functional imaging. Her present appointment is as Senior Research Fellow at NIMHANS. Her contributions to the field of speech and hearing are that she's participated in several conferences and webinars as guest speaker and paper presenter. She has also received awards for best paper and poster presentation in these conferences. She has 2 publications and 5 published abstracts to her credit, and she is the working committee member of IAPEN, WFNR, and IFNR. Ma'am, I would request you to take it up from here and share your screen.
Thank you so much, Pooja, for such a wonderful introduction. I request Prasanna to share his screen.
Just give me a moment. I'm getting the slides up.
Okay. Meanwhile, we have a panelist today. We have a representative from Stroke Support Group, that is Mrs. Shruti. And we have a stroke survivor and a family member, Mr. Mohsin and Mr. Wasim. Can we have you, Madam and Sir, please? I request Mr. Mohsin and family and Mrs. Shruti to switch on your videos so that we can see you.
Hello, ma'am. This is Mohsin Khan, relative of a stroke survivor, Wasim Khan. He's my brother. Yes, ma'am. Ma'am, you are not audible to me.
Thank you so much. We have Wasim Khan, who is a stroke survivor, and we have Mohsin Khan, who is a family member. Do we have Mrs. Shruti Bhushan? Can you please check on that?
Ma'am, one minute. Actually, my brother is very weak in English. So if you ask questions in Hindi, so he'll be better way he'll answer.
Yes, I'll try to do that. Thank you.
Yes, Hindi.
Okay, before, can we go for the first question? Prasanna, can you please check on if we have Mrs. Shruti?
Yes, yeah, you can carry on. I'll just
Yes,
find out
yes,
everything.
yes, yes. वसीम खान जी, आप अपने बारे में थोड़ा बता सकते हैं? छोटे शब्दों में बोलिएगा, बहुत ज्यादा कुछ बोलने की जरूरत नहीं है, हम मोहसिन खान जी से पूछ लेंगे वो। आप आपके बारे में बताइएगा।
अच्छा, मैं 31 इयर्स का हूँ। 31 इयर्स का हूँ मैं।
नाम क्या काम करते हैं?
नाम मेरा वसीम
आपका
खान।
नाम?
वसीम खान।
आप कहाँ के रहने वाले हैं?
और मैं मुंबई का रहने वाला हूँ।
अच्छा, आपको ये जो निगलने की दिक्कत है वो कब से है, कितने दिनों से है?
लगभग 7 हफ्ता हो गया है।
5 हफ्ता हो गया है, ठीक है, थैंक यू। 7 okay. Okay, we have Wasim Khan with us, who is a resident of Pune, and it's been 7
Mumbai.
weeks that Mumbai, and it's been 7 weeks that he has complaints of dysphagia post-stroke. Mr. Mohsin, can you please introduce yourself and what are the problems that was faced by your family?
Yes, ma'am. Actually, I'm Mohsin Khan, brother of Wasim Khan. Ma'am, my brother Wasim Khan is 31 years old, and from last 5 years, he's suffering from cardiomyopathy, that is heart disease. Because actually, it is not suffering from 5 years. We come to know about it before 5 years, and his LVEF ratio is about 15 to 20%. LVEF, I don't know what exactly meaning of it, but that ratio is 15%. And from that, the blood pressure and the everything, we are taking the treatment of everything in Mumbai. तो मैम तब से लेके हम जब लास्ट ईयर भी क्या हुआ था कि इनको ना एक ऐसा कोविड से एकदम सडनली ये नीचे गिर गए थे, और इनका 1 हफ्ता ये हॉस्पिटल में एडमिट थे। तो वहां से आने के बाद उनको कोविड वार्ड में डाल दिया। फिर उसके बाद में इधर आने के बाद में इनका वापस से 1 महीना हम लोग ने ट्रीटमेंट किया। इसके बाद में पूरा 1 साल प्रॉपरली हुआ, और लास्ट 6 to 7 वीक्स बिफोर इनको अगेन वैसी सेम चीज हुई, और अचानक से सर दुखने लगा, और सर दुखने के बाद में सडनली नीचे बैठ गए। पूरा सर जो बहुत एकदम पेन कर रहा था, और पूरा पसीना पसीना हो गया था। और दैट टाइम वी रियलाइज कि ये कुछ निकल नहीं पा रहे। इनको पानी दिया तो कुछ निकल नहीं पा रहे थे, और कुछ खा भी नहीं पा रहे थे। उसके बाद में फिर हम लोग ने हॉस्पिटल में एडमिट किया, और फिर उनका ट्रीटमेंट वहां से स्टार्ट हुआ, और हमको पता चला कि इनको डिस्फेजिया भी हो गया है। एंड बिकॉज ऑफ लो ब्लड प्रेशर मैम, इनको वाटर रेस्ट्रिक्शन है हार्ट की वजह से। तो जो भी मतलब फीडिंग हम लोग करते हैं, दैट इज 1.5 लीटर का रेस्ट्रिक्शन दिया था डॉक्टर साहब ने। तो अभी जो भी जाता है मैम पेट के अंदर, तो 1.5 लीटर ही है। तो ओवरऑल मील इज 1.5 लीटर। तो इसकी वजह से ना मैम एक्चुअली हो क्या रहा है कि जो इनका वेट था पहले और जो अभी वेट है, वो दो बहुत ज्यादा मतलब डिफरेंस आ रहा है इसमें, क्योंकि लिक्विड रेस्ट्रिक्शन होने की वजह से अभी कुछ सॉलिड भी नहीं खा सकते।
Okay, so we have their complaints on dysphagia post-stroke, and we'll move to next question so that we know more about what are their awareness and what was the challenges faced by the family. Mohsin ji, what was it like when you knew that your family member had a stroke? What was in your mind? What was the first thing that ran into your mind?
Actually, ma'am, this disturbed the family. Actually, when we come to know about this thing, so that time, एक तो financially, mentally and physically, तीनों तरीके से मैम पूरी फैमिली डिस्टर्ब हो जाती है। एक्चुअली एक मिडिल क्लास फैमिली से मैम हम लोग का एक शॉप है इधर ही मुंबई में, और मेरे भाई पर शॉप पे ही काम करते थे। बट बिकॉज ऑफ दिस ये अभी बाहर काम पे भी नहीं जा सकते, कुछ कर भी नहीं सकते। तो तीनों चीज से मतलब फैमिली डिस्टर्ब हो गई है अभी।
Okay, so it says that there is disturbance in the family life, quality of life. The
Yes, yes.
breadwinner of this earner of this family is these two brothers, and it has affected their family life. Can we move on to next question?
Just an update. Miss Shruti has joined in.
Okay.
You can direct questions to her as well.
Okay. Welcome, Madam Shruti. We have Madam Shruti as a stroke support group representative. We welcome you, ma'am.
Yeah, hello.
Yes.
Yeah.
Yes, madam.
Am I
Ma'am,
audible?
can you? Yes, ma'am. You're audible. Ma'am,
Okay, fine.
we request you to introduce yourself. Where are you from, and which stroke support group you represent to?
Yeah, sure, sure. My name is Shruti. My husband, I am from Bangalore. My husband, Mr. Gururaj, suffered stroke 4 years back when he was 42. I am representing Stroke Support India. That it was both an ischemic and hemorrhagic stroke. Later, the blood test revealed there was proteinase deficiency, and he had earlier a ventricular septal defect closed with a patch. So this was his history. And though I had read about stroke, myself being a science student, till at that point of time, I could not make out it was a stroke. And the treatment started in the golden period itself.
Yes. Thank you, ma'am. So we have Mrs. Shruti from Bangalore, who represents stroke support group of India. My next question is, what was your understanding of stroke and dysphagia before it happened to your family members, or has it happened to your family members? Has it changed now? If yes, how? I would want Mrs. Shruti to answer this. After that, I request Mr. Maushin to answer.
Yes. I must say, whatever the understanding of stroke that we will be having before, it will help. But at that point of time, I could not recollect the factors that will lead to stroke. Only after a call with the doctor confirmed it was a stroke. Then after 4 years now, definitely perspective of stroke has changed. What I feel is a lot of awareness which is being created about stroke is very good for the society. Still, I don't know how many people will pick it up about stroke. We are all so busy, so busy. We just read an article, leave it there. When it happens to a near and dear one, the image or the picture about stroke itself changes. So the same is with me. After 4 years, whatever the idea I had about stroke and what the effects are has changed completely, because he suffered aphasia and right side hemiparesis, and he is on regular rehabilitation and he is improving. But yes, definitely the way we see stroke and life after stroke is entirely different when we face it with our family member.
Yes, ma'am, I understand that. I want viewpoints from Mohsin ji.
Yes, ma'am. Before the stroke, actually, my family, there was no one in my family who suffered from dysphagia. So we don't know about anything about it. The thing like this can happen. कि किसी को निगलने के लिए भी कुछ problem हो सकती है, and this is the big thing. But after the stroke happens and when doctor confirms about it, so after that our entire perspective regarding this change. Because अभी person को खिलाना ही नहीं है कुछ भी, because the liquid का तो restriction है, और जो भी जाने वाला है वो सिर्फ liquid के form में जाने वाला है, तो it changes the things like कि अभी सब कुछ change हो गया अभी life में. अभी प्री स्ट्रोक एंड पोस्ट स्ट्रोक का तो एकदम पूरा की पूरा चेंज है मेरे फैमिली में, मैम.
Yes. So we have Mr. Mohsin saying that his understanding of dysphagia has changed after it has happened to his brother. And we have Mrs. Shruti who says that the stroke has changed their life. Once it happens to their near and dear ones, they know the consequences of it, and they know how serious and how important it is to know about stroke. Okay, we have, can we have next question? We have Mrs. Shruti. Can you tell us how it has affected your family's quality of life? The stroke.
Yes. Post stroke, there is definitely a change in the quality of life for the entire family. It is 100% with the person who suffers it, Not only that, with the spouse and the children and the entire family, now we plan everything according to my husband's schedule, and whatever the food we give to him, whatever his diet. So we all go with it so that it is easier for me to manage the household. And financially, definitely it matters a lot, even in terms of rehabilitation and the way we face society or the way society sees us. Recently I felt that there is, I don't know if people agree with me, sometimes there is less respect in disability. That is what I felt. We have to be strong enough and face things. Whoever thinks what, it doesn't matter to us anymore. We are focused, we have a goal, yes, we have to reach it. That's fine. But the quality of life changes totally, and our routine also changes entirely. We suit everything to my husband's needs.
Yes, I want to know this particular answer from Wasim Khan ji. वसीम खान जी, ये जो स्ट्रोक होने के बाद में आपको जो निगलने की दिक्कत हुई है, उसके वजह से आपकी रोजी जिंदगी में कोई फर्क आ रहा है कि नहीं? हमें पता है आ रहा है, पर आपके मुंह से हम सुनना चाहते हैं कि आपको क्या क्या दिक्कतें हो रही है।
मुझे खाने में बहुत दिक्कत होती है मैम, मेरा पेट नहीं भरता है, भूख लगती है।
He says he has difficulty because of eating and swallowing, and he eats but it doesn't fill his stomach. That's the concern that he has. So we have a lot more to do in this field, and awareness on the same, and working on with the nutritionists for the same, right? We're moving on to the next question. Is there anything that you wished that should have been better in terms of services or during the time of hospitalization? Mrs. Shruti, can you please answer on this?
Yes. Thank you very much for asking this question. This is a very, very important question. This is what I felt, and what I felt personally. I request the panelists not to take my answer otherwise, but even I would like to be part of any group or any voluntary organization which would like to create a lot of awareness at the hospital level. Because what I faced personally was, there was not very good training about dysphagia because my husband was on tube feeding and we were worried. But once he was out of tube feeding, I felt that he started gaining his strength. We were not advised much at the hospital level, and I was worried about the cleanliness of the tube. Why so? Because if the previous feeding food has remained even little bit, that should not cause any sort of infection. We were not trained for it. Absolutely no information was given, even though we went to a very good hospital, I must say, stroke ready hospital. Okay. And the second thing is, since he had aphasia, there was no assessment done at the hospital level, and nobody gave us any guidance. I did not know much about a speech therapist then. We had to search for everything by ourselves when we, at the time of discharge. I feel a lot of awareness is required at the hospital level itself, so that when the patient goes home, he knows something like this is required. Probably even a bed, hospital bed. Some patients may require, that hospital bed or an elevated bed or a bed pan, or even if they're in tube feeding, how to maintain tube feeding, what to give to the patient. I think more education to the patient's family is required regarding all these things, and especially that he had aphasia. I thought I will get more support from the hospital. I don't expect them to come home, but in terms of guidance, so this is called aphasia. I didn't know the word aphasia, for example. This is called aphasia. So you should search for a speech therapist, or this is called dysphagia. This is a swallowing disorder. These are the precautions you should take. Or this is, we will motivate the patient. Yes, slowly you can eat. But how much does that motivation help? We should not overdo things. At the same time, we should not pull the patient down. So it should be a balancing act. So I request, the eminent panelists, if something can be done at the hospital level, it will help a lot of patients. This is my humble opinion.
Yes, ma'am. So we have a need, we have a request that there has to be a lot more awareness on the field of speech language pathology and dysphagia, which we will have to take it up. And the first most important thing that we are doing is public awareness. I think it includes all public specialists, even the professionals. So can we hear from Mr. Moshin? What are your viewpoints on this?
Yes, ma'am, definitely. Ma'am, when we got the discharge from the hospital, that time, what we were expecting is that at the time of discharge, they should tell us about everything, everything about the dysphagia, because this thing changes the daily routine. Because आप खाना नहीं खा पा रहे हो, आपको जो भी जा रहा है ट्यूब से जा रहा है, तो like you can see my brother, and there is a tube. So whenever you there is 1-2 days gone, तो 2 से 3 दिन के बाद में you have to replace that वो stick जो होता है, जो tape होता है, उसको निकाल के आपको replace करना पड़ता है. But whenever we remove that ना, तो उनको इतना दर्द होता है, तो how to remove that, उसको कैसे properly उसको stick करना है, उसको कैसे रखना है, कौन से position में रखना है, ये चीज का proper awareness discharge के time पे हमको होना चाहिए, जो कि हम लोग को एक्चुअली में नहीं होता है, कोई भी हॉस्पिटल में नहीं मिलता है प्रॉपरली. तो ये चीज मैम मैं बोलना चाहूंगा कि ये अवेयरनेस यहाँ पर होना चाहिए, दिस थिंग. एंड सेकेंडली इज व्हाट कि जब सपोज आपका कोई भी मतलब एक पेशेंट है, जैसा कि कोई हार्ट पेशेंट है, बिकॉज माय ब्रदर इज हार्ट पेशेंट, तो ये कंडीशन में और भी ज्यादा केयर की जरूरत पड़ती है. दैट्स व्हाई कि अगर आपका ब्लड प्रेशर भी बढ़ जाता है, तो उसका हार्ट पे बहुत ज्यादा भी इफेक्ट पड़ सकता है बिकॉज ऑफ दिस. बिकॉज अभी मैम लास्ट वीक जब मैंने मेरे भाई की जो टेप थी लगी हुई, उसके टेप को जब मैंने चेंज किया ना, तो ही वाज लाइक शिवरिंग. उनको ऐसी वो हो रहा था, इतनी घबराहट हो रही थी. तो दैट टाइम आई वाज एकदम शॉक कि कुछ और नहीं हो जाए इनको, सिर्फ पट्टी चेंज करने के लिए, बिकॉज उनको यहाँ पर ये गले में पूरा दर्द हो रहा था. एंड उसके बाद तो मैं ऐसा सोच लिया कि बस अब जो लगी है इसको ये भी रखना है इसको प्रॉपरली. तो ये चीज के बारे में थोड़ा अवेयरनेस मिलना चाहिए.
Okay, so the need is on do's and don'ts when you go out of the hospital. What are the things that has to be done when a patient is going out who is having dysphagia and nasogastric tubes, and their cleanliness? Everything is a need. So this brings out the need of awareness and information, providing information to the family members and caregivers, which is in dearth. Yes. Can we have next question? I would like to ask Mrs. Shruti, what are the challenges that you faced for rehabilitation, means therapy for dysphagia or related to stroke?
Yes, initially we got a physiotherapist coming home. We had to search for a speech therapist, but that physiotherapist, he was not particularly trained for stroke. So slowly we came to know that stroke, to train for a stroke, it's better the physiotherapist is trained in neuro specializations. That was when we came to know late. Okay, and in the hospital, I had to go running behind the, I'm telling you, very good hospital, very reputed hospital. I had to go running behind the physiotherapist, and I had to go and get them. Please come, please attend to my husband. Or I had to pay the security guard and ask, did the physiotherapist come today? What happened inside the ICU? So we have done all these things. We don't get any information outside till they come to the ward. And once they come to the ward, the whole burden is on us, as if they've come home. And we are not educated. When we go home, what do we have to look out for? If it is a physiotherapist or a speech therapist or a dysphagia specialist, I must say, after joining the support group itself, I came to know about the term dysphagia, and there are so many eminent persons in this field who are working hard to spread awareness. But in the hospital setup, we don't know. So now I am making use of the opportunity of being a support group member to tell whomever possible who have problem with dysphagia, I am telling people there are specialists who are very well trained. You have to go to them. You have to take their advice. Majority of persons don't know who are in support groups. And I'm sure Prasanna Hegde sir is also part of the group where people keep posting questions. We are not at all aware about it. That is regarding dysphagia, the maintenance of the tube or the cleaning or the alternate feeding methods, or how to change over from tube feeding to normal feeding, because taking patient every time from home to hospital again is a challenge. That is regarding dysphagia. Second thing is speech therapy. Yes, of course, Broca's aphasia, where there is total loss of speech. There are lot of challenges, even with swallowing, even when there is problems with swallowing. That kind of guidance I did not get. And with physiotherapy, we have therapists for some amount of time, and we have to do it at home. We can do it, but not in a very initial stage where we don't know the difference between spasticity and flaccidity. Now we know because we are attending so many seminars, so many sessions. That time we don't know. And any wrong exercise, will cause harm to the patient. So right kind of advice is a must. That is what I feel. One more thing I want to express through this forum is, if there is a checklist for a person with dysphagia, the disorder might be anything. It may be stroke or anything else. During discharge, at the time of hospital, or for aphasia, or for stroke, I did not see any such checklist in the hospital, whether so-and-so has been tested, or whether what the person is able to do now, whether the caregiver is trained. If such a checklist is there in hospitals, it will definitely help the patient and the patient family. Finally, I must tell you, it is the patient who is suffering. We will support them, but we can't take their pain. It will definitely help the patient to recover better.
Yes.
This is
With all
my
this,
feeling.
Yes, with all this, I understand that support groups are a help. They are a ray of hope at present. You get connected to people and get to know more in terms of what to do, what not to do, and what help you can get it. Right?
Definitely, definitely.
Yes, yes. Can we have Mr. Moshin answering this? What was
Yes,
your
ma'am.
challenges that you faced when you were going for rehabilitation? मतलब थेरेपी के लिए जा रहे थे ना, निगलने की दिक्कत के वजह से, तब आपको क्या-क्या चुनौतियां दिखी, उसके बारे में थोड़े बताएं।
यस मैम। मैम स्टार्टिंग जो था, तो जब हम लोग डिस्चार्ज जब हुआ, तो दैट टाइम वी डोंट नो टू whom वी कैन कंसल्ट। तो ENT स्पेशलिस्ट के पास हम गए, हमारे पास के जो डॉक्टर थे उनके पास गए। फिर वहाँ से उन्होंने बताया कि आपको स्पीच थेरेपिस्ट के पास में या तो फिजियोथेरेपिस्ट के पास में आपको जाना है, जो वहाँ पर आपको इसका आपको प्रॉपर्ली ट्रीटमेंट मिल सकता है। तो दैट वाज द पॉइंट, जब हम लोग को मतलब इतना इसको समझने में लगा कि हमको एक्चुअली बताना किसको है प्रॉब्लम, कि एक डॉक्टर जो हमारे ENT स्पेशलिस्ट है उनको बताना है या इसका कोई और इलाज है। बिकॉज हार्ट प्रॉब्लम होने की वजह से डॉक्टर ने हमको बताया कि आपकी जो नर्व्स होती है हार्ट की एंड आपकी जो swallowing की, वो बहुत पास होती है, तो वी कांट ट्रीट। मतलब इलेक्ट्रिकल शॉक का एक मेथड होता है, आई डोंट नो द नेम ऑफ दैट पर्टिकुलर थिंग। So we can't do this with your brother because he is suffering from dilated cardiomyopathy, तो वो भी नहीं कर सकते। तो आपको एक स्पीच थेरेपिस्ट से ही आपको कंसल्ट करवाना चाहिए। तो इतना ही स्टार्टिंग में प्रॉब्लम हुआ था मैम कि हाउ टू whom we can reach and to whom we can tell our problem। तो स्टार्टिंग में इतना ही हुआ, बाकी तो अभी डॉक्टर ने हमको प्रॉपर्ली किया है मैम, प्रॉपर्ली हमको ट्रीटमेंट भी देते हैं। यस।
Acha. So this brings out the importance of contraindications of different methods used in dysphagia intervention, and the problems faced reaching the speech language pathologist or dysphagia specialist for their needs. So this brings out the importance of timely referrals. Our next question is, what was your commitment for rehabilitation? Mrs. Shruti, can we have you? What was your commitment for your rehabilitation or therapy, that you wanted to go for the therapy? Mrs. Shruti, can we have you?
Oh, I'm sorry, I was on mute. Yeah. The first thing is the age of the patient. He was just 42. Whatever is the age, their improvement will add to their comfort. So once they start improving, they will start feeling better. They will feel confident they can do much more, so that they can improve little more, little by little, one small movement, or they're able to eat on their own. It will give them confidence and that independence. So they will try something else. So in this way, to make the person feel better, that is first thing, age of the person, then the family responsibilities, trying our best to get them on track as much as possible. Even if slowly, even if it takes time, it's fine. As much as possible, to the best of their abilities. I wanted my husband to, face the society. Like, it's not like something has happened, I should sit in a corner. Not like that, not like that. Yes, we have to face it. Still, we are in a better position than millions of other people in this world. We have a loving family. We can do much more better. So it is all about the person who has suffered a stroke. If he feels better, he is able to do better. He is confident that he can face. So bring him back to the best of his abilities. So this was the main motivation. And the second thing is, definitely we have tried alternate therapies. One problem we will face at this point of time is lot of suggestions. Sometimes, either family or friends, we don't know what to take, what not to take. But yes, definitely motivation, self-motivation helps a lot to help the person do better.
Okay, so getting back to normalcy, getting the
Yes.
family life, all these are the motivation and commitment that has helped them to work on the intervention. Can we have
Yes.
Mr. Moshin answering, what is your commitment for your brother's rehabilitation of swallowing or stroke or
Yes.
different problems that he is facing?
Yes, ma'am. First of all, you have to be strong. Whenever these things happen in your family, so family will definitely will disturb. Your family will disturb. तो सारे के सारे लोग अगर अपनी हिम्मत छोड़ देंगे या फिर ऐसा कुछ हो जाएगा कि हम लोग अभी कुछ कर ही नहीं सकते, तो दैट टाइम फैमिली का पूरा के पूरा मोटिवेशन चला जाएगा. दैट टाइम आपको एक उम्मीद रखनी है, आपको एक हौसला रखना है, और जो पेशेंट है उनको ये बताना है कि यस, ये हो सकता है और क्यूरेबल है आपकी प्रॉपर थेरेपी से. तो ये थिंग मेरे को ऐसा लगता है मैम कि ये चीजें अगर हम लोग करते रहे तो इसमें पॉजिटिव आपको रिस्पांस मिलेगा. और एक कमिटमेंट भी ऐसी करते चलना है कि यस, हम लोग ये इतने टाइम में हम लोग बिल्कुल भी कुछ ना कुछ तो हो जाएगा इसमें करेंगे, तो दिस विल इम्प्रूव. जो भी आपके साथ में है वो डेफिनेटली इम्प्रूव होगा. और इन्वायरमेंट को जब हम लोग आसपास के इन्वायरमेंट को जब हम लोग पॉजिटिव रखने की कोशिश करेंगे तो डेफिनेटली उसका भी असर पड़ेगा मैम. बिल्कुल.
Okay, so the positivity and getting better is the hope. Okay, so I think that's very important for us to be committed to help patients with dysphagia more, so that we give more positivity and a better recovery. We expect a better recovery and hope we help them in a good way so that we bring back them to normalcy. I'm not asking much question to Mr. Wasim because I don't want to tire him. Okay, whenever I would want him to answer one or two questions, I'll bring him in. So
Yes.
Next question is, what is the role of support groups? Though we have got most of its answer from Mrs. Shruti, can you please highlight on role of support groups? Mrs. Shruti, please.
Yeah, sure. Thank you. To be very frank with you, I was not at all aware support groups do exist in exist in India. So what happened was, my husband, he chanced upon in Facebook, and last year itself, just last year I joined, probably after around 2.5 years or after his stroke. But the kind of knowledge I have been getting and motivating each other, people motivate each other on the support group. The kind of seminars that have been organized about alternate therapies or physiotherapy, speech therapy, to put light on the subjects which are most important to us at this stage of life. They are helping a lot. I must tell, they are very motivating, they are very eye-opening. and lot of information which is required. We may have some myths, we'll be able to come out of it. It is definitely helping a lot, to connect to each other, to stay motivated. Yeah.
Okay, so the exchange of information in the group definitely helps, and a concern from some other person who is suffering different difficulties are helping many of the patients who are in those groups. Okay, our next question is, what do you expect from the professionals dealing with stroke, specifically dysphagia? Mohsin Khanji, can you please answer this?
Yes, ma'am. बेसिकली मैम जो एक्सपेक्टेशन हमारा जो हमारे डॉक्टर से उनसे ये है कि व्हेनेवर जैसा कि अगर इन फ्यूचर सपोज अगर कुछ ऐसा प्रॉब्लम होने वाला है या होता है डिस्फेजिया में कि कुछ इम्प्रूवमेंट दिख रहा है या फिर ऐसा कुछ हो रहा है, तो वो लेवल पे हमको आगे क्या करना है उसका अगर हम लोग को पहले से नॉलेज होगा कि अगर सपोज आपको स्ट्रोक हुआ है, स्ट्रोक होने के बाद में सपोज अगर आपको यहाँ पर और ज्यादा कुछ प्रॉब्लम हो रहा है तो वो केस में आपको क्या करना है, या फिर आपको इम्प्रूवमेंट हो रहा है तो तब क्या करना है, ये चीज का अगर हम लोग को पहले से अगर डॉक्टर बोलेंगे कि क्या करना चाहिए ऐसे केसेस में, या फिर एक्सरसाइज के बारे में हो मॉर्निंग इवनिंग आफ्टरनून, तो ये चीज के बारे में अगर पहले पता चलेगा तो वी विल डू इन बेटर वे द थिंग्स वॉट एवर वी आर डूइंग इन रेगुलर on regular basis.
Okay, so it means that informing your patients what are the possible
Yes.
precautions they'll have to take, what are the exercises or what are the intervention approaches you will work on, or informing them. Knowledge is something that they want, and I think that's everybody's all the people who are working in dysphagia, I think they can give this information and it will help them. That's what we get to know from Mr. Mohsin's expression, right? Okay, our next question is, what is your advice to stroke survivors and their families? Since we have both of our panelists having suffered this or having seen this in their family, फर्स्ट आई वांट टू आस्क वसीम खान जी, आप क्या बोलेंगे दूसरे स्ट्रोक सर्वाइवर जो है उनको आप क्या बोलना चाहेंगे, या फिर उनकी फैमिली को आप क्या बोलना चाहेंगे?
मैम उनकी फैमिली को तो मैं यही बोलूंगा कि थोड़ा धीरज रखो, थोड़ा टाइम लगेगा लेकिन हो जाएगा। मैं खाली
Yes.
टाइम बोलना चाहूँ।
We hear it. It will take time, but it will be all right. That's what Mr. Wasim Khan, the stroke survivor and who is having dysphagia, says us. There is a ray of hope. It's just a matter of time. Can we have Mrs. Shruti saying us, what do you want to
Yes, yes.
give? What's your advice?
Sure. Stay strong, stay motivated, never give up. Good days will come. Keep trying. It is neuroplasticity which will work for you. Definitely good days will come, but please keep trying. The number of repetitions, it's good. Keep practicing every day. Good will happen. And improvement is a continuous process. In between, if you feel or somebody has said that there is a stage of plateau or anything, don't listen to it. You just keep trying. It will happen.
Yes.
Good will definitely
Thank you
happen.
so much. Thank you so much for bringing out an individual's commitment is very, very important.
Yes.
Practice is very important, and it is a timely process. It is giving the time for the brain, that is neuroplasticity, to take over different functions is very, very important. Thank you so much, Mrs. Shruti, for bringing it. Can we have Mr. Mohsin, a family member of a stroke survivor? What is your advice to the stroke survivors or the families who are facing this?
Ma'am, first of all, I just wanted to tell them कि stay strong, because अगर आप उतने strong नहीं हो और आपके अंदर उतनी खुद के अंदर उतनी अगर hope नहीं है, तो आप आगे नहीं बता पाओगे, आप जो stroke survivor है उसको handle नहीं कर पाओगे, because the stroke survivor wants motivation. First of all, he wants motivation. उसको बताना है कि he will do that, and वो होके ही रहेगा और वो हो जाएगा. It is curable. तो ये बात मैम सब जितने भी स्ट्रोक सर्वाइवर्स है या फिर उनके फैमिली मेंबर्स है, मैं उन सबको बताना चाहूंगा कि यस, कीप होप्स, ये होता है और ये हो जाएगा, ठीक होता है।
Thank you so much for saying that. Motivate your family members, keep hope, it will be all right. Okay, so my last question is, what is your advice to public, not the family members? What do you, आवाम को आप क्या बोलना चाहेंगे? मोहसिन खान जी।
यस मैम, मैम जनरली क्या होता है कि व्हेन वी गो आउट, जैसा कि अभी दिन भर तो घर में रहते हैं, बट एक सडनली रात में एक थोड़ा सा राउंड लगाना है, बिकॉज इज सफरिंग फ्रॉम हार्ट ना, तो वो ज्यादा चल भी नहीं सकते, तो थोड़े टाइम के लिए हम लोग जाके एक छोटा सा राउंड मार के, तो दैट टाइम व्हाट क्या करना पड़ता है कि जो मास्क तो लगाते ही है, पूरा कवर को मतलब फेस को, नोज एंड माउथ को मास्क से कवर करती है, बट ये जो पाइप है उसको भी कवर करना पड़ता है हमको। तो जनरल पब्लिक में एक थोड़ा सा ऑडनेस फील होता है, मेरे जो भाई है उनको। तो एक मैं जनरल पब्लिक को ये मैसेज, मतलब एक रिक्वेस्ट करूंगा कि जब भी आपको ऐसा कोई पेशेंट दिखे, तो आप उनके साथ में कुछ ऐसा नॉर्मल बिहेव करो कि आप जैसा दूसरों के साथ करते हुए। इट इज नॉट लाइक कि अरे ये कुछ है, आप उनके साथ में एकदम काइंडनेस मत बताओ कि यस ही इज डिफरेंट, उनको एक नॉर्मली ट्रीट करो और वो उसी से मोटिवेट होंगे। यस, मतलब ऐसा करना है कि वो भी ठीक हो जाएंगे, ही इज ऑल्सो नॉर्मल। क्योंकि मैम जब भी ऐसा होता है, मैम जस्ट वन थिंग, कि जब भी ऐसा होता है कि कोई पब्लिक रिएक्शन से उनको ये फील होता है कि ही इज डिफरेंट, तो उनको अपने आप में एक वो अलग चीज आ जाता है कि आई एम पेशेंट। जब तक उनके खुद के दिमाग से ऐसा कोई बताते रहेगा कि यू आर पेशेंट, तो उनको प्रॉपरली, मतलब अपने मेंटली वो अपने आप को प्रिपेयर नहीं कर पाएंगे ठीक होने के लिए। यस मैम।
Okay, so it means that it is not being sympathetic, it's being it is about showing empathy and accept them as they are, which is very important. And this is the words that has come from a family member. I would want Mrs. Shruti to say what is your advice for the public?
In my personal experience, yes, it is the same thing as you said, being empathetic, not sympathetic. Second thing is, let there be no loose talk. I mean to say, didn't you do this? Didn't you do this? Everybody wants the family member to improve well, do well, have a nice personal life. They would have tried in terms of their knowledge or in terms of their background. Everybody would have tried their best to bring up their family member. You should have done this. You would have become much better. You know, that kind of loose talk definitely doesn't, it neither helps the family nor it motivates them. Second thing is, what I have seen lately is, in the public domain, there are most of the places are not disabled friendly. Even though there are many rules, many guidelines, still I feel they're not being able to follow. Though yes, it is being followed in many places. I don't mean to say every place, but still I think we can make some places friendly for them, so that they will also be able to go out and they will also have a better quality of life. It so happens that when we want to go, we will think whether they will have a proper bathroom facility or a washroom facility or not to go to that place. So I think in terms of facilities, some more facilities are required so that they will have a better quality of life, that even they are able to come out. Once they start involving themselves with the society, their improvement will be much better. This is what I have seen and felt.
Okay, so having a disabled friendly environment is very, very important.
Yes.
And it will improve their quality of life. This is what has brought out of this discussion. And that was our last question to everybody. And I thank our panelists, Mrs. Shruti, Mr. Mohsin Khan, and our stroke survivor, Mr. Wasim, for having joined us, bringing out so much of information and asking us to work towards disabled friendly and information, providing information on different disabilities that we do. I'm sure we as a society commit to this public awareness and also awareness in the professions in the coming days. I thank all of you to having joined here. Thank you so much for bringing out your experience in this forum. I thank all the three of you. मोहसिन जी धन्यवाद, वसीम खान जी धन्यवाद, आप यहाँ पे आए और आपका समय हमको दिए उसके लिए धन्यवाद।
Thank you so much.
Thank you, ma'am.
ये हम सब के लिए एक इंफॉर्मेशन, मतलब हमारे लिए आसान होगा आपकी दिक्कतों को समझने के लिए, और हम इसके बारे में आगे के दिन में काम करने की कोशिश करेंगे। धन्यवाद। थैंक यू। पूजा, you can take over.
Thank you.
The last 2 hours, I'm sure, have been extremely enlightening and enjoyable. As we come to the end of this webinar, I would like to express my heartfelt gratitude to everyone who has made this a success. I would like to call upon Ms. Preeti to give the vote of thanks.
Thank you, Pooja. Good evening, everyone. It's my pleasure to deliver the vote of thanks for this awareness program on the theme of dysphagia in stroke on the occasion of World Stroke Day. I thank everybody as an academic chair of Society of Feeding and Swallowing Disorder. I would like to thank the resource persons of today, Dr. S.P. Goswami and Dr. Jayashri Bhatt. I would like to thank the panelists of today, that is Mrs. Shruti, Mr. Wasim Khan, and Mr. Mohsin Khan. I thank the technical team, Mr. Prasanna and Mr. Bhushan. I thank the president, Dr. Mansi Jagtap. I thank the secretary, Mr. Prasanna. I thank the EC members of Society of Feeding and Swallowing Disorders. And I would like to thank volunteers who have volunteered to this program, specifically Ms. Pooja Sriram, who have worked in making this and organizing this event. I also thank the audience who have stayed up for this long and making up this event a success. Once again, I thank one and all who is present here. Have a great evening. Before we leave, can we have our seniors say a few words? I think we have Premlata ma'am. We must be having, ma'am, can you please say a few words? Do we have Premlata ma'am? I can see Dr. Shivani Tiwari. Ma'am, do you have anything to say? Okay, so I don't see anybody else. Anything that you want to share before we leave? Pooja, anything?
Ma'am, I'd just like to thank the stroke survivor and the caregivers who came up here. I don't think we can even begin to imagine what they must have gone through. We can only sympathize with them, but they were so brave to come forward and share their stories on a platform like this. And we may have all the theoretical knowledge in the world, but I think we have to learn from people like them to learn and modify our ways of functioning. So I'd like to thank Mrs. Shruti, Mohsin, and Wasim Khan once again for being on this platform. It was a really nice and very moving panel discussion, I must say.
Thank you so much. So if we have nothing, we can leave. Thank you, everyone. Thank you, everyone, for being there, and such a wonderful evening. Thank you. Bye. Good night.